Hi, good morning, everyone. So I realized the first two speakers, I have the easiest job. I just have to fix the fracture. So, seeing that I have the easiest job, I have deliberately made my presentation very simple so that it could stem some interest in you guys, and hopefully we'll have more collaborative efforts in the future and better communication barriers when dealing with metastases and cancer between the orthopedic surgeons and the oncologists, cardiologists, pulmonologists, nurses, etc., etc. So let's start. Right, so learning objectives. The learning objectives, hopefully at the end of this presentation, is to understand the clinical burden of skeletal metastases, because it's quite common and frequently missed. Review indications and principles of surgical management. Of course, in Trinidad and Tobago, and by extension the Caribbean, we have significant challenges. Examine validated scoring systems. We wouldn't spend much time on that. Discuss preoperative care and outcomes. Cost is important, and the limitations that we have in a low-income country, and evaluate ethical considerations. So let's start. So we weren't able to get much epidemiology in the Caribbean, but in the States we have at least 350,000 patients per year with skeletal metastases. Using ChatGPT, we were able to get some information in the Caribbean where the incidence of prostate and breast cancer in Barbados is about 131 patients per 100,000 patients. And in Martinique, 152 to 100, so roughly in the hundreds per 100,000. Breast cancer is 70 to 78 per 100,000. What we do know is that 70% of metastatic prostate and breast cancer involve bone. So if we were to use some mathematics and we could apply the percentage, the 70%, to the numbers, and we should be able to get a reasonable figure, probably about in the incidence of prostate cancer, around 70% or 131, we'll be able to get a reasonable figure of how many of these patients with metastatic disease actually have metastases to their bone. Of course, some of the common cancers in the Caribbean are breast, prostate, lung, and kidney. And in terms of the bone, the frequent sites for metastases are the spine, the femur, and the pelvis. There's a rising cancer incidence in low and middle income countries, and unfortunately a late presentation. Why? Because we have lack of screening tools. Even if we do have the screening tools, the access to the screening tools, even if we do have the investigative tools, the delay in getting the investigations done, especially in the public sector, is a huge issue. For instance, where I work, if you are diagnosed with cancer, CT scan, you usually get it within a week, but MRI scans, sometimes you wait over a month for a MRI scan. PET scans, we get 2 PET scans per month in Mount Hope at Eric Williams Medical Sciences Complex, in which the government pay for to allow these patients to go privately. So 2 scans, such a high incidence, wouldn't really do much in terms of improving the quality of care that we offer. Limited access to oncology services. Where we work, we don't have oncology. We frequently have to refer these patients to St. James, other public systems, and of course the communication gap there is quite difficult. Most times we wouldn't be able to communicate on the phone, so we have to write referral letters. Imagine writing a referral letter for someone who has cancer and waiting on them to respond with a next referral letter. And then when the referral letter comes in and it goes into the clinics, you have to wait quite a few weeks to access the response to your last referral. So you could see the difficulty we have and the time frame in managing these patients. Scarcity of radiotherapy machines and appointments, restricted therapeutic options due to limited resources. These are some of the issues that we are faced. in a public system. Now let's look at the pathophysiology of metastases to the bone. It's hematogenous, so it spreads via the bloodstream. And we tend to pick up two different types of metastases, either osteolytic, we're not going to go too much into those, or osteosclerotic. So when you look at a plain X-ray, you either see a radiolucent image or a sclerotic image. And of course, the radiolucent is due to increase in osteoclastic activity that resorbs bone, and a sclerotic image is due to an increase in osteoblastic image, in which you increase the activity of the osteoblast that deposits bone. So prostate, breast tends to give an osteoblastic, thyroid follicular cancer, multiple myeloma tends to give an osteolytic. But there are many, and some tumors actually give a mixed picture. Now, let's look at the surgical indications. When are we useful as orthopedic surgeons to the rest of the medical fraternity? One, when the patients have intractable pain due to metastases, when it's affecting their mobility and their function. Sometimes they may not have a fracture, but they may have an impending fracture. And of course, there are scoring systems that we would use for these. When the patients have neurological deficits, in the case of spinal metastases. Indications, sometimes we are not able to improve their survivorship, but certainly we could offer palliative care. The care that we offer and the service that we offer has to be cost effective, especially in a public setting. We must be able to minimize complications. Early mobilization is the key to prevent the complications associated with being in bed. And of course, our goal ultimately is to restore previous function. Here are some of the challenges we are faced with. Limited availability and accessing to images and implants. The key word there is implants. Sometimes even if you get the image in a short space of time, the required gold standard implant is not available, neither public nor private. Why? Because these are costly. They have to be tailored to suit the patient's size. If we do get approval for the implants, then there's a time frame, there's a gap in us requesting the implants from a first world country and having them ship it down here. So often at times, even if we do get access, unfortunately, we have to do what we can at the point in time to stabilize the patient, which obviously will not improve their life expectancy. So, decision-making framework. This is for patients who have impending fractures. Of course, there are many scoring systems which you all don't need to know about, but we need to know about. And these are scoring systems when we, as the orthopedic surgeon, have to decide whether we should fix or prophylactically fix an impending fracture or whether we need to observe the fracture. And of course, this is just to show you guys our mind frame and our school of thought when we're approaching patients who you all refer to us with a lesion. So not all of them need to be fixed. Some can be monitored, and it's important to note that in our setting, fixing these fractures could actually spread the tumor along the bone and increase the risk of developing further pathological fractures along that bone and require more advanced implants for these patients. So some metastases we do observe and rely on radiotherapy, chemotherapy, immunotherapy to help treat that lesion. Right. So let's look at some surgical options available in our setting. We have rods, we have plates, we have screws, we have nails. We don't have all these fancy prosthetic replacements. We don't have all these fancy instruments, that 3D printing instruments that you all tend to see. So unfortunately, we have to rely on the resources that we have. And these are some pictures that I would like to show you guys how we manage tumors and how it can be managed in a high-income country that has all the resources. So in this slide, I'm not sure if okay, so in this slide you can see that this patient has a small lesion here. Now what we would tend to do is put a nail as you all can see on the middle slide and the last slide, to sort of stabilize the fracture. Now, in this case, we essentially pushing that tumor, from the proximal aspect of the femur throughout the entire shaft. In a first world country that has resources, they could actually remove the entire femur and put in what we call an endoprosthesis. Yes, it's probably a bigger operation. Yes, probably increased blood loss. But when tackling metastases to the spine, the importance of imaging is to decide if your surgical intervention could offer curative therapy versus palliative therapy. And now let me break this down. Let's say a patient presents with prostate cancer or breast cancer. They did a CT of the abdomen, pelvis, chest, it's clear, and they have an isolated lesion in the femur. Now, by removing that entire femur or that segment of femur, you could actually offer this patient curative intervention and improve their quality of life. By nailing the femur, which is what we shown in the previous slide, we offer palliative care. We're not getting rid of the tumor. We're actually spreading the tumor down the entire shaft. So if this patient predicted life expectancy would have been 10 years, we may have now downgraded that patient life expectancy to probably about 5 years or 3 years, because bone metastases does affect your quality of life significantly, and intractable bone pain leads to loss of mobility and all the complications associated with loss of mobility, such as bed sores, blood clots, etc., etc. Again, next patient, what we do here is we use a nail or we use a plate if someone has a spread of cancer. This bone, by the way, is the humerus. So if the patients have tumor spread to the humerus, what we would tend to do is try to curate out the tumor, resect the tumor, place some antibiotic cement, bone cement in there, and nail the bone to give them functionality. But again, in a country with resources, we could actually replace that spread, that metastases, with the intention of curing this patient so that their quality of life and that spread along the further bone would not be an issue. So these are things that are available not in a third world country. We may have access to it in certain situations, but the time frame for these implants to reach us, they have to be custom made to suit the defect of the tumor that you resect. It takes some time, and most often we can't wait, and we have to do what is necessary at the point in time. This is just another way. This is a shoulder implant for tumors that spread to the shoulder. We could remove the entire shoulder, and we could do hemiarthroplasties and total arthroplasties for the shoulder in a first world setting. Back here, what we left to do, unfortunately, is nail the humerus, regardless of where the tumor is, whether it's on the shoulder, the shaft, or distally, we do the same. Next patient here has a tumor, as you all can see. This is a lytic lesion going straight down the shaft. What we tend to do in our setting, when you all send the patients to us, is we would put in a normal, what we call a half of a hip implant. So we actually leaving the tumor inside you. We're trying to stabilize. We would cement it in place to give them some mobility. We're not improving their survivorship. We're improving their mobility and pain. We have had access to these implants in the past, but again, it does take some time for these implants to reach. By doing these, we actually removing the tumor and increasing their survivorship. Sorry about the slides, but I think this is probably the best way to capture the audience, because I'm just seeing one surgeon here, and that's me. So I know probably speaking about it in terms of more information wouldn't appeal to you all as piteous would. Some tumors, it's not always about metastatic lesions. Some tumors, especially GCTs, giant cell tumor, although they are benign, they can spread. they can't spread to the bone. And one of the most common locations for these tumors to spread is around the knee. Fortunately, because they are benign, even though they can spread, these are one of the few tumors where we can curette the contents of the tumor. We could burn it, we could burn the cavity, we could use dyes to kill the residual cells, and we can, in fact, just put bone cement there and plates and augments to help improve stability. But this is one of the exceptions to the rule in terms of skeletal metastases, where by simply using bone cement, we would not affect the survivorship and the quality of life in these patients. Unfortunately, these are far and few in between. Just another example, what we do here. If you look at the shaft of the humerus, we have placed cement in there. And what we use the cement for, you'll probably see a lot of these slides where we put cement in addition to an implant, is that the cement, when we mix it, it gives off an exothermic reaction. Temperatures could actually go up to 70, 80 degrees Celsius. And we're hoping that that exothermic reaction could actually destroy some of the tumor cells in addition to the fixation. So we try our thing as orthopedic surgeons. We try to kill a little bit of cancer cells in addition to the oncology agents that really kills the tumor cells. So we do, so we do a bit of our own oncology here as well. But what should really be done? What should really be done for these patients is resection of the entire tumor and placement of what we call an endoprosthetic implant. And with these, yes, we still need to screen the patients to ensure that we don't have any residual tumor spread. This is just another example of a tumor where we could use allografts. So the defects in treating tumors is quite important. They have two options. When we have to treat large defects, we could either use endoprosthetic, which is synthetic implants, or we could use allografts where we get similar sized bones from cadavers. Unfortunately, we don't have a bone bank here in Trinidad and Tobago, so it's equally expensive for us to import allograft options. So we tend to use autograft, where we take the graft from the patient's hip, particularly the layer crest, so we could use their fibula on their leg, which in itself has donor site morbidity. So it's important to understand that taking graft from the patient does lead to some issues, and they're already having pain. Now, pelvic metastases is a bit difficult to deal with. Unfortunately, despite the treatment that is recommended in low and middle income countries, most patients with pelvic metastases maybe have about 3 more months left, and even the treatment that is advocated, we can't practice it because blood is an issue, especially with pelvic metastases, quality of life, loosening of the implants, infection. So most times we just rely on the oncology centers for radiotherapy and chemotherapy for these patients. And these particular group of patients with pelvic metastases unfortunately have to be bedridden, and they don't last quite too long. But if we do have access to resources, these are some of the fancy stuff that we can do. And with these, the patients can actually immediately weight bear the following day and help to improve their quality of life. These are just different fixations for pelvic metastases, for proximal femur metastases, etc. Now, post-operatively is important with the timing of radiotherapy, the timing of chemotherapy, wound care. A lot of these patients are compromised, immune compromised, not just with regards to the cancer, but also with regards to nutrition. So nutrition is quite important for these patients. We have seen quite a lot of wound care and wounds breakdown in these patients, especially seeing that some of them on chemotherapy or post-op radiotherapy. These are some of the outcomes, the figures. In high-income countries, they do have 80% of improved pain and mobility, whereas here we do have about 50% improved pain, but we do have good mobility post-operatively. So in conclusion, these are just some of the challenges that we are faced with in accessing imaging, in accessing the quality of implants for these patients. And of course, by not accessing these in a timely manner, it will affect their quality of life and care. Must remember it's a multidisciplinary team approach, and we need to practice enhanced recovery after surgery. And future directions, AI is important, and robotic surgery, surgical navigation in order to resect tumor is things on the horizon, and if we ignore it, it will pass us by. Thank you very much.